As
All right,
always.
well, welcome everyone to our ongoing AO Trauma Hand Internet Live session. Tonight we're pleased to be joined by Hill Hastings. Hill is an Emeritus Professor of Orthopedic Surgery from Indiana University, and he's now, we'll talk about this in a little bit, he describes it as semi-retired in Telluride, Colorado. Hill trained in general surgery, microsurgery at the University of Colorado, then did his residency in orthopedic surgery at Harvard, fellowship at Indiana Hand to Shoulder Center, Indiana University, where he then made his career from 1981 to 2015. And again, he describes himself as semi-retired, but he's got a lot of involvement in Telluride. These are our disclosures. Obviously, Hill has a number of them, and we're going to talk about some of these. Myself and Kim Mesra, who's going to be our moderator tonight. Just a word on Zoom etiquette. All of your microphones have been muted and the videos turned off. However, we do certainly encourage your participation. We'd like you to do that through the Q&A function through Zoom. Kim Mesra is our moderator, and she'll be fielding your questions and then at the appropriate time present them to Hill. So again, use that Q&A function. For those of you who have joined us, this is a list of those that we've already done over the past number of weeks. Still coming up is Neil Ford Jones and Doug Hannell, so you'll want to pay attention for that schedule. And then a link to the recording will be available in 24 hours. AO has a YouTube channel where you'll be able to get that. And again, that'll be uploaded for you to review. Our other ongoing webinar series, 13 or 14 weeks we've been doing this, and actually this Thursday is the last week. It's for those in senior residents and fellows getting ready and some tips for life after fellowship. So please stay tuned for that. Again, in addition to Hill that we're going to be spending our evening with, Kim Mesra is going to help us out and field your questions. So thank you for joining us. We put together a very clinically based talk to give some insights into Hill's career. The way this is set up, we have a number of sections based upon things that Hill has been formative in. And each of these sections is sort of started with a case. So this first case is a 63-year-old right-hand dominant woman who had a left elbow fracture as a child. She now complains of pain and limited range of motion in her left elbow. Next is her radiographs. And as you can see, pretty significant radiocapitellar and ulnar trochlear arthritic involvement going along with her poor motion. So she underwent total elbow arthroplasty, as you can see here, and then did well, and follow up here. She is 7 years later, maintained her motion and good function, and very pleased with her results. So this sort of sets the stage for us. And I put together a series of questions that I had, and I think will be interesting for us. As many of you know, Hill was involved in the design and the development of the Discovery elbow. So at the time, just to set the stage, the prevailing implant was the Coonrad Mori. And I wanted to sort of pick his brain on what was his inspiration for developing this implant compared to that. Problems, pioneering a new design, reflections on working with industry, and then for those of us that do total elbows, some tips and tricks and surgical technique and some rehab tips and tricks, and then if he had it to do all over again, what would he do differently?
Okay, well, thanks, Jeff. I'll see what I could do with this. So unlinked arthroplasty, I was experienced with that in the early 80s with the capitellar condylar. The advantages are minimal bone resection, but the inherent risks are instability. It's a little tougher to restore soft tissue balance. Some of the unstemmed humeral implants can migrate, and this was an example of a capitellar condylar that I did. She did great for 6 weeks, and then she fractured off a very tenuous ulnar collateral attachment and required reconstruction of her ulnar collateral. I visited Willie Suter in Edinburgh in '89 and started using his implant. This is one of the failures with a total polyethylene ulnar component that subsequently was revised to a metal back component. The second generation sloppy hinges, such as the male modified Coonrad, have been kind of the mainstay. And I used that through the 90s. And I started seeing a high rate of bushing failure that seemed to be under-recognized by others and certainly in the literature, with cases leading to ugly black particulate polyethylene debris, as you see here, failed polyethylene bushings. At times, it would disassemble, and here on the right, you see a osteolysis that ended up to a fatigue fracture of the humeral implant. Tom Wright in Gainesville and I looked at a series of our cases in the 90s and felt that there was really high small area loading on the eccentric surfaces of this implant that can lead to polywear, polyethylene debris. Eventually you get metal on metal contact, the index being the C-ring popping off. We felt that when there was more than 7 degrees of varus valgus on stress, it showed significant wear. And when there was more than 10 degrees, total failure of the bushing implant. So I felt we needed a better way of accurately and reproducibly positioning the elbow flexion extension axis, a better way to distribute contact forces over a larger surface area. Other than a true hinge, we wanted to provide stability without a hinge. In individuals without a radial head, ideally preservation of their ulnar collateral ligament to protect against valgus stress. Most of the implants had set sizes for the humerus and ulna, and there are often times where we felt we needed a different size humerus and a different size ulna. And the male modified Coonrad at least required connecting the elbow before impacting the humerus in all the way, which is a tricky step. The anterior flange, which provides additional support and rotational support, can sometimes impact against the coronoid, leading to pistoning and loosening of the ulnar component. And also it's a little bit difficult to bone graft underneath that. So what we came up with was a hemispherical design that you see here. We studied this in the lab during the development of this, and our moderator, Jeff Lawton, recently, a year ago, published their look at the Nexel and the Discovery, pretty much underscoring that, yes, it does share load over wider surfaces areas in both varus and valgus. Most joints, hip, knee, elbow, tend to fail through the poly, so we thought we needed a method for exchange of the poly if needed. And the poly we incorporated was a highly cross-linked vitamin E poly that's been shown to be resistant to wear and oxidation. So this was a combined project with Tom Graham and along with the engineer at Biomet, Bernie Berlesman. So we undertook 3D analysis of the humerus, ulna, and the canals in order to get perfect geometry for the stem, with the tenet that the stem really dictates where the axis is. So for example, on this upper left, you see a male modified Coonrad in red with the axis reproduced well. But if you truly put the stem a line down the course of the ulna, all of a sudden the axis of the elbow is not where it should be. So the stem really is important, and the morphology is important in reproducing the axis perfectly. On the right, you see the recessed anterior flange that sits directly against bone. So the pros, well, the pros of working with an established company is they have great engineers. They have the ability to generate prototypes, and they have support with patent and legal issues. Biomet was very responsive in helping develop this elbow. We went through several reiterations, lab testing, bench testing, and so on. Obviously, industry has a wide distribution system and teaching capabilities, but On the other hand, incentives may not always be aligned. So clearly, elbow is a small market compared to shoulder, hip, and knee. And so there may not always be the same incentive for industry to follow what physician designers really need to be done. So for example, we developed a discovery radial capitellar replacement, a Hemi, revised ulnar bearings, revised condyles, and they were slow to implement that, even though we did bench and lab testing and stress testing and all of that. And then some may know that Biomet was acquired by Zimmer, and that slowed down some of those developments either further. And what you see on the right is a part of the discovery system, which is a skeletal reconstructive system that we developed with the discovery, and that was retained by Zimmer, with the discovery kind of split between DJO, Zimmer, Biomet, and Lima. Well, so some tips on doing things. A lot of surgeons have been used to describing the approaches as either triceps sparing or triceps preserving. I think that's pretty confusing. So I prefer to use triceps on or off, which makes it very clear. So I advocate triceps off on all cases in an early surgeon's experience. Cases with marked contracture or where the humerus is eroded into the ulna are difficult for exposure, so the triceps off makes it a lot easier. And most revision cases where you have to explant components and perfectly see anatomy to redo them, triceps off is an advantage. Triceps on, as I'll talk about, certainly can be done with primary simple cases without contracture. It is the go-to way for distal humerus fractures, and with experience, it can become the go-to experience for most surgeons. There are several options. The most popularized was the Brian Morey approach, where you detach the triceps and reflect it laterally. The mirror image of that is the extended Kocher, where you detach the triceps and reflect it medially, and it is possible with that same approach to leave the triceps and ulnar collateral completely intact. I'll show you quickly a distal-based triceps flap, which I believe is the easiest way and predictable way to do it, and also a method for revision. So the simplest is simply a posterior incision with a distally based tricep flap that leaves Sharpie's fibers of attachment completely intact. A colleague, the late Simon Frostick, looked at 100 discoveries that he did with this technique with basically no triceps failure. Here's a quick video just showing this, the back of the elbow. This is just elevating the central triceps, leaving a margin of tendon medially and laterally, and you leave the attachment to the olecranon completely intact. And then deeper, you make an incision midline, and then as you come down the olecranon, it's very simple. You just simply subperiosteally elevate the tissues away laterally, as shown here, and you do the same thing on the medial side. It's helpful to mark the corners as you take down the medial and lateral sides off the olecranon, and these can be sewn back to the base of this tricep flap on closure. So it preserves triceps vascularity. It doesn't require torquing the elbow, and it gives you great exposure. The ability to separate the elbow is accomplished by the subperiosteal release laterally, and then down the medial side all the way up to the coronoid anteriorly, and then the elbow will easily dislocate. You basically have to take down 3 sides of the elbow. That's true of pretty much any joint that you want to totally dislocate. Surgeons have been mostly taught to release the collaterals from proximal, but I think that it's a lot more predictable and far more reliable with respect to healing when you release the collaterals distally. So that's not generally known. And then on closure, they simply fall back into position. So you don't have any specific repair required. This implant lateralizes the stem of the implant, so it does allow you to preserve the normal tension on the ulnar collateral, and in many cases, you don't even need to take down the ulnar collateral, which helps serve again as a tension band for absent radial heads. Probably the biggest mistake I see surgeons make using this prosthesis is they don't make a deep enough slot into the proximal ulna. So you need to take a 5mm burr and make a generous slot. And then as you rasp, you need to torque the rasp posteriorly. So you truly rasp down the length of the axis of the elbow, and that'll place the proximal axis in the proper position. Triceps on, when we first started, we used incisions medial and lateral to the triceps like Alonso Yames. And it's easy to buttonhole the humerus off to the side, but it's more difficult to see and prep the ulna. And rotational alignment is particularly important for the ulna, as studies have shown that if it's malrotated by 10 degrees or more, it does lead to accelerated loading and poly wear. So most of us over time have migrated to what we call a lateral paraolecranon approach. So you make an incision in the lateral third of the triceps. So the medial 2/3 is completely intact. You retract this lateral triceps laterally, and that respects the 15-degree angle between the olecranon and the olecranon shaft and puts you in the best position for rasping and reaming down the axis of the ulna. For revision cases, you oftentimes need more proximal exposure. And if you try to retract the triceps all the way off to one side, that's difficult. So a Gauchand split, just a midline split, is the easiest way to do that. It gives you great extensile exposure for both the humerus and the ulna. If you were to go medially with a Brian Morey, oftentimes you need to redissect the ulnar nerve, and it can be densely scarred, difficult and dangerous to do so. So this is the easiest way to do so. Recognize also that with fracture and with revision cases where you're lacking the distal humerus, the more proximal humerus becomes very voluminous. So here, for example, is a 6mm stem. You can see how small it is within the diameter, which would lead to a very large cement mantle. So as part of this project, we developed the SRS comprehensive system that allows you to choose various diameters of stems and various lengths of humeral stems, and then various lengths of buildup for the discovery distally. And this has been a great tool for revision surgery. So here's that case where the male-modified Coonrad broke. The humeral and ulnar stems were still secure. Here's a window in the humerus and a window in the ulnar for getting those out. And then this is the SRS with a modular length of anterior flange that you can choose. Here it is in position. Here's her motion on the table. And then here's her motion at 6 weeks. So we usually don't start motion till 2. She has fair flexion at this point and fair extension. So would I do it again? Yes, of course I would. I think for all of us, it's really rewarding to take on a new problem and work collaboratively towards a solution. Of all the things I've been involved in, I've realized that it's not a one-step process. You need to develop, test the prototypes, study it, run anatomical labs, put it into clinical practice, and then study your results. And there's oftentimes progressive changes or tweaks that need to happen. But I think the downside is, there's no assurance you can maintain control if you work with established industry. Perhaps the ideal is to develop your own company and do it that way. But for me, this was a good way to go.
All right, excellent. So our next case is arthroplasty, but of a different fashion. Again, as many of you know, Hill developed the Hemi-Hamate Arthroplasty. So this is a young lady who injured her left ring finger some time ago. So it's a subacute injury, and she's got this sort of missed or untreated PIP fracture subluxation. She's got pain, limited range of motion, and as you can see, that ring finger is deviating away from the middle finger, and it's scissoring over the small finger. So that's the axis where things lie. That's her cascade. But again, you get the sense that that ring finger needs to be over more adjacent to the middle finger. In addition to getting her more motion and decreasing her risk of developing arthritis, we want to point her ring finger in the right direction. So these are a couple representative cuts of a CT, and you see this dorsal subluxation with this central impacted type fracture. that again is now subacute, deviated, well healed. So we chose to reconstruct this with a Hemi-Hamate arthroplasty. So this is her ring finger. You're looking at it end on. The head of the proximal phalanx is to our right. The base of the middle phalanx is to our left. And then you can see this volar portion of the middle phalanx where the articular surface doesn't look so healthy, and the dorsal, it looks much better. So we did a Hemi-Hamate arthroplasty, again, harvesting from the fourth, fifth CMC joint. Here you see the graft. And again, he'll tell us about his inspiration for this, but you can see that the intracondylar sulcus there, that's nicely recreated with this graft. And then you can see it implanted in the next slide. So again, we're taking it from the dorsal aspect of the hamate and rotating it around, in this case, to the volar aspect of the middle phalangeal base. And this is looking at it and appreciating the anatomy end on. So you see the hamate to your left and the base of the middle phalanx to your right. And again, you see that intracondylar prominence that's going to recreate the base of the middle phalanx for us nicely. Clinically, so here's this young lady. We have our graft in place, secured by a couple of 1.0 millimeter screws. And then you can see in the next slide with her joint reduced, how her cascade is now restored, so that ring finger is now pointed where the ring finger is supposed to be pointed. And then you can see fluoro pictures, and then healed pictures, and she did very well. And you can see her motion, again, a little extensor lag, not surprising, but good range of motion and good function. And she was very happy with it. So I wanted to try to get Hilda to share with us his inspiration, what he feels are the indications and maybe some contraindications. When is it too late? You know, in other words, we want to be careful that when we're a hammer, not everything is a nail. So when is it too far gone? And then obviously some tips and tricks with regard to both the surgery and then what he's found through the rehab in these patients.
Thanks, Jeff. Well, the popular technique has been the volar plate arthroplasty, first described by Eaton and Malarich. And in the 80s, I found that unfortunately this wasn't very predictable in my hands. We had the occasion for Dick Eaton to give grand rounds, and we did 3 cases with him the following day. The pins were removed at 3 weeks, and unfortunately, despite this, they redislocated. John Ernst and I, was a fellow of mine at the time, thought that, well, maybe a dynamic external fixation could help with the stiffness, but also maintain congruity. So looking at biomechanics of the PIP, we found that there was, in fact, an instant center of motion that coincided within a millimeter, on the basis of which you could design a fixator, a mobile fixator. And so we applied this to volar plate arthroplasty cases, and then unfortunately, repeat dislocation still happened once the fixator came off. So we looked in the lab. This is Ward Hamlet doing a study with me, taking away a portion of the articular base of the proximal phalanx. And what we found is that up to 42% you could get rid of with no instability problems. And then as you get up to 50%, as you see here, it's congruent mostly up to extension, but then as you start to flex, the joint simply hinges and then caves into that compacted defect. It didn't matter in this case whether the collaterals were intact or sectioned and the joint dislocated. The collaterals play no role with dorsal palmar stability. And once you lose up to 62% of the joint, it doesn't matter what position you hold the joint in. Basically, you have to hold it in more and more flexion, the more you take away. And after you get to 60%, it's unstable in all positions. Bruce Steinberg was a fellow with me, and we looked at various options from tendon to toe. And in the lab, these are some of Bruce's dissections looking at possible osteochondral grafts from the hand. So he created a defect in the base of the middle phalanx. We thought that the dorsal hamate might be a suitable option to place to restore the volar base. This is one of the first cases done in the lab just with pins or K-wires, on the basis of which we recognized that it restored immediate stability and could allow for early range of motion. So the indications have come to be comminuted, unstable PIP fracture dislocations, just like the index case that we just showed. Both acute and neglected. Sometimes you'll have just a single lateral plateau from a deviation injury, and all too commonly, unfortunately, we see it needed for salvage after failed treatment by X-fix, open reduction, enteral fixation, or palmar plate arthroplasty. I don't really know when damage is too bad. So here, for example, is very damaged proximal phalanx. Here's kind of what's left of the dorsal base of the middle phalanx. Obviously, you need good flexor and extensor mechanism, soft tissue coverage, and you really do need a patient that can comply with postoperative therapy. So in young adolescents or rebellious individuals, you may need to take care. Here, for an example, is a case that presented at 7 months. One of my partners, Rick Eidler, it looked like this had too diffuse of arthritis, but given the options of replacement or fusion of his index, we went ahead with hemi-arthroplasty. And here you see the injury to the head of the proximal phalanx. Here's the hamate graft. Here it is secured with screw fixation. And he, in fact, turned out to be one of the better matches. There is some morphologic variability to the hamate. And then he did fine, full flexion. And then I think, as pretty much all my cases, there's some mild residual extension deficit or passive flexion and contracture, which is usually not an issue, but I think that's pretty typical. Here's probably the worst case, someone who had been prolonged dislocated for a year or more, the base kind of riding on the dorsal metacarpal, but part of the dorsal joint intact. Here, the hamate is in position. The hamate has thicker cartilage than the middle phalanx, so you will see an offset apparent on X-ray, even though you know the cartilage lines up perfectly. And I think the reason some of these late cases still can do okay is because the palmar part of the joint still may be relatively intact as it articulates both with the graft inflection and the more dorsal part in full flexion. So some tips, I'll give you 2 tips. So we take a rectangular graft from the hamate. This is the base of the 4th and 5th. And there's variability in how lax the carpometacarpal joints are. The osteotomy is most accurately performed inside the joint. And with a lax joint, that's not a problem, but in a tighter joint, it's hard to get your osteotome in. So the trick is simply to take away the dorsal part of the 4th and 5th metacarpals. It will no longer articulate anyway. And this gives you the perfect axis for taking this graft, which should go deeper as you go more proximal. So it goes from distal dorsal to proximal deeper. And I'll show you that in a minute. So the second tip is the most important thing to make sure people do well, is to reproduce the concavity of the articular base. If you fail to do that and it comes out too flat, then you end up with dorsal palmar shear forces that can break the joint down. There are 2 tricks to doing that. The first is to make sure the distal part of the graft is thicker than the proximal part. So there again is the need for that angle as you do the osteotomy into the hamate. One may be tempted to simplify the defect in a rectangular position. It's actually better to leave a little ledge distally and to make your simplification of the recipient bed a bit of an angle. And then that in itself leads to tipping of the graft. Those of you who have done it will notice that the distal part of the graft sometimes can be prominent, almost always is a bit prominent. You can just simply excise that as your screw fixation is proximal to that. Rehab, there's nothing secret about that. If you try to move them too early, they're just too swollen. So the answer is usually 3 to 5 days, usually 4 or 5 days. Edema control is critical. You can work on active and passive range of motion. We usually do put a 5-degree dorsal block splint just to protect the repaired volar plate at the end of the procedure. And healing's usually sufficient enough by 6 weeks so you can begin strengthening. And if there is any residual passive flexion contracture, you can start working with that. So in a nutshell, that's kind of the tips, the two main tips, I think, for making it work well.
Excellent. So our next phase is going to introduce a topic that Hill has been around throughout the evolution. And this is a case of a 17-year-old high school quarterback who injured his right wrist. The trainer taped the quote-unquote sprain. He made it through summer conditioning and the entire season, and then came to see me after his season, and he's got this very small proximal pole scaphoid non-union with avascular changes. You can see it looks sclerotic. So we performed a vascularized bone graft. And to orient you, this is the 1-2 ICSRA. So this is a right wrist. The thumb is up and to the right. The elbow is to your left. You see the Freer elevator pointing at the pedicle. You see the prominence of the second dorsal compartment and then the first dorsal compartment in the background. And then in the subcutaneous tissue, you see the radial sensory branch. So this is what it looks like when we harvest our graft. And then we go ahead and insert it. Here you see his radiographs with insertion. And then healing, I get a CT scan to prove trabecular bone bridging. He did well, and you can see his range of motion. It's his right wrist, and again, a little loss of extension, but you know, I'd take this 10 times out of 10. Good range of motion, good deviation, and he got back to his level of sport, finished his high school, and then went on to play in college. If you want to advance, Hill. So we're going to talk about a reflection of where we've been with the Zeidenberg graft, and it came out, and like many things in hand surgery and orthopedic surgery, was supposed to, if you go back one, Hill, it was supposed to address a specific task, and it was maybe a little too widely applied, and then fell out of favor a little bit. We looked at our group in a very specific population of very small proximal pole fractures in 12 patients, and had 100% union in an average of 11 and a half weeks. So we're happy with it in these cases. And I just wanted to get Hill's reflections on some of the pearls of the relevant anatomy. And again, looking at the whole time span of where we've been with the vascularized bone graft, beginning with the wide adaptation of Zeidenberg, then falling out of favor, other pedicled flaps and grafts, free medial femoral condylar graft, and then the thought that, well, do we really need this anyway? And isn't it just good carpentry that we need and just cancellous bone and a compression screw? So where does Hill think it sits now?
So this is a big topic. I'll give you a little history on this. So in the center, upper center, you see some latex injection studies that Carl Zeidenberg and I did. And the pertinent anatomy to the 1-2 ICSRA that Jeff just presented. And you can see it here coming off the radial artery and then coming back proximally underneath the brachioradialis. There are vessels between each of these compartments, and they provide blood supply distal to the epiphyseal plate. So you can take vascularized grafts also from Lister's tubercle, from the floor of the fourth compartment. You can use them in different carpal applications. We also determined that there are volar carpal arteries off the communicating vessel between the anteroosseous artery and the radial artery that can be similarly harvested as a vascularized bone graft and rotated. I'll talk about that. For many, many years, people used vascularized iliac crest grafts, and more recently with the Mayo Clinic, the popularization of the medial femoral artery graft off the descending genicular vessels. Carlos and I tried to determine where the biggest amount of vascular bone was, and this is some India ink injection studies. We also tried with gadolinium, and we found that the biggest area of vascularity was about 12 millimeters proximal to the radial styloid. It's interesting, if you do this in an adolescent, you'll see the epiphyseal plate, and you'll see that it's vascular distal to that and not so much proximal. But as the epiphyseal plate closes, that zone of vascularity extends much more proximal. So this is really a blood supply distal to the epiphysis that then becomes more generalized once the epiphyseal plate closes. Is it better? Yeah, vascularized grafts are better. This is a canine study by Alan Bishop and colleagues at the Mayo Clinic. They took a canine model carrying out a fusion of the wrist with vascularized grafts. One graft, they did cryotherapy to the graft, and none of those healed. My former partner, Greg Merrill, with the late Joe Slade, looked at 5 studies using for proximal pole non-union with 88% success with vascularized bone grafts and 47% without, and a trend towards better results when there was previous surgery. Here's a large series, a large meta-analysis of articles, 5,000 plus patients, again showing a trend with just cast 80% union, non-vascularized graft with internal fixation 84, vascularized 91. So there is a trend towards better and quicker healing with vascularized grafts, but yes, you don't always need them. And a number of studies have shown that non-unions can heal with a non-vascularized graft through a simpler way of just adding cancellous graft and screw fixation. So where did this sit? So this is my former fellow, Jenny Green. She practices in Australia now, looking at Carlos's and my cases, 106 cases. Basically, we found 92% union confirmed by CT or in Argentina experienced by tomograms. If you look at the Mayo Clinic experience, lesser union rate 72%. And very important is that humpback deformity was predictive of non-union. So it's hard to sort out the variables between one study and another, success in another, because there are many reasons for failure. A number of studies have shown that union rates are twice that in non-smokers as smokers. And as we found, and also the Mayo Clinic study, 50% of the failures were failure to correct deformity. Also, previous surgery can affect, and a number of studies have shown that success rate diminishes with longer durations, particularly with non-unions over 5 years, which relates to osteonecrosis. Probably our ability or inability to correct deformity perfectly is illustrated here by Lottie Nagy and Schweitzer in Switzerland, looking at 9 patients with patient-specific 3D guides, reproducing anatomy within 7 degrees, and by conventional freehand, 26 degrees. So we're not always as good as we think we are with just freehand correction of deformity. I think one of the really important concepts that was put forth by my friend Uli Buchler and Lottie Nagy, where they classified non-unions into class 1, as you see in the upper right, where basically the fracture plane is proximal to the dorsal ridge vessel. So the proximal pole becomes avascular. And early on, the trabeculi are pretty normal. You have osteoplastic activity. Most non-unions still have osteoplastic activity, but if you have motion and time going on long enough, then you get osteoclastic activity that takes over. And as you see here, you get trabecular failure. You get collapse of the trabeculi. They crush and collapse on each other. The proximal pole looks more dense. And basically, in class 1, you have intact vascular and trabecular network that can pretty quickly revascularize. In class 2, you don't have really intact structural trabeculi or vascular networks that can easily spread vascularity once healing starts to happen. So it really comes down to this. It really does come down to biology versus carpentry. So with vascularized bone grafts, there's clearly an advantage in time to heal. It adds osteogenic potential, but it is more difficult with respect to carpentry. On the other hand, non-vascularized grafts, it's easier carpentry-wise to restore a good stable buttress. But the downside is you're stacking up non-viable tissue, or poorly viable tissue, I should say, in the middle. So here, for example, is the 1-2 ICSRA. And as you rotate that distally, the width oftentimes becomes not wide enough to really serve the mechanics of what you need. So this works great for scaphoid fractures and small cystic non-unions, but it may fail with larger ones. You should also recognize that many non-unions you can handle just by screw fixation alone if it's a fibrous union or minimal sclerosis. Smaller cystic deformities you can handle by arthroscopic bone graft and fixation, or open graft and fixation. But we're really talking about non-vascularized versus vascular comes down to the humpback deformities with large cystic change in bone loss more than 5 millimeters. And clearly, if the proximal and distal fragments are vascular and they're reasonably large, the easiest way is cancellous bone graft and a screw. So where do we sit? Well, I agree with what Jeff has shown us. For small proximal pole fragments as seen here, the 1-2 ICSRA is the easiest way. It's adjacent to the scaphoid. It's easy to rotate it into position. Where it fails, and I think where it's gotten a bad name, is in the larger defects with long-standing non-unions, with scant or absent vascularity, and perhaps some of the minor class 2. And this is where volar grafts really fit the bill, I believe. This is an article just published this year by cases from Greg Summerkamp, Jeff Greenberg, and myself, looking at the pedicled palmar radiocarpal artery. You can see this is a class 2. You can see there's cystic and collapse deformity. It looks like it's quite distal, but if you look at the sagittal view, in fact, it's a oblique non-union with only a very small proximal pole. So here is the harvest spot. It lies very ulnar and distal, and you free it up on this communicating vessel and rotate it in. And it gives you a sizable cortical cancellous graft. So in this study, we looked at 15 patients, all had avascular proximal poles. We looked at CTs at 6 and 12 weeks to determine the percentage of healing across the non-union site, and found that at 6 weeks, all of them had at least 70% healing across, and then it further progressed after that. There are times where it doesn't work. This is one of my failures out of that 106 case series, deformed proximal pole, and you're better off a salvage method such as proximal carpectomy or a slack wrist reconstruction. So that's kind of how I look at it, and it takes studying the scaphoid to really figure out where you are with it.
All right, so now we're going to switch gears a little bit. This is a 32-year-old woman with pain and limited range of motion, and this is her in the OR flexing her right elbow. So in this case, we did a capsulectomy through a medial approach, and you see the column type approach, and going anteriorly excising capsule, either decompressing or transposing the ulnar nerve and going posteriorly. And then here you see her doing well and happy with her return of motion after capsulectomy. So I wanted to get Hill's thoughts on how to treat contracture, what his indications are for capsulectomy, how he chooses to go medial, to go lateral, maybe when not to offer a capsulectomy. And then also as a little side branch, without getting too far down the rabbit hole, talking about the role for interposition arthroplasty and possibly even hemi-arthroplasty. Thanks, Hill.
Okay, Jeff, you're challenged to me. That's a lot to cover. So it's been shown that, or thought that, a 50% reduction in elbow motion reduces upper extremity function by almost 80%. So a functional arc is somewhere 35 to 130. I rarely see patients present requesting something be done until they've lost at least 40 degrees of extension. So the indications are when they fall outside this functional arc. Most of the time, lateral is the way to go. It's simpler. And it's certainly the way to go when you have contracture without any ulnar nerve problems. You can always add a small medial incision for in situ decompression. And oftentimes with trauma, more often than not, the pathology is about the radiocapitellar joint or posterolateral ulnar trochlear joint. So it's simpler and easier. It's obvious to see overgrown olecranon and coronoid. So the essence is to debride those, take out capsules, but oftentimes what's missed is the gutter enlargement. And so you don't see this on plain x-rays unless you get an axial view or a CT. And these can cause pain, impinge, and limit extension. It's easy, other than arthroscopy, which is a whole nother topic, it's easy to get at these laterally and also to add a small incision medially here through the medial head of triceps posterior to the ulnar nerve. And that takes you right down to the medial gutter. And here you see the medial olecranon. When I first looked up our post-traumatic cases, 23% of the time, my approach was medial, and that was mainly to transpose the ulnar nerve, decompress the nerve. Here, for an example, is a nerve encased with heterotopic ossification that required extrication and transposition. Obviously, if you need to reconstruct the ulnar collateral. Earlier in this series, I often felt we needed it for application of a compass hinge or mobile fixator, but now I think it's easier to do with just a unilateral fixator or internal joint stabilizer from the lateral side. So that's changed a little bit. As to young and post-traumatic cases, interposition versus hemi-arthroplasty. Here, for example, is a young rheumatoid in his 20s, interposition with tendon Achilles and a mobile fixator applied. What are the results of these? The largest series from the Mayo Clinic, 69 patients. But if you look at the details of this, they excluded 7 of the failures. And even with that, they still ended up with 14 fair and 11 poor, or basically 2/3 were fair or poor. So not so good, I think. And a lot of that depends, and I think relates to the necessity of restoring the radial head. This is the technique I used that was recently written up, published June of 19, applying a plate laterally, removing the plate, carrying out a lateral epicondyle osteotomy, exposure of the joint for tendon Achilles interposition, and then reapplying the plate. And then this is his x-rays. He also required a distal radial ulnar joint replacement. Hemi-arthroplasty, I don't have that much experience with it because it's not FDA approved in the US. You have to use it as a custom device. So here, for example, is a discovery with an add-on hemi and replacement of the radial head. All the studies have come from outside the United States, and I'll just reference one by Greg Bain and colleagues who collated all the studies reported until recently, which were 121 cases, feeling that the indications for acute distal humerus fracture that can't be fixed in active older patients. When it was applied to salvage from failed non-union or OIF, the results weren't as good. So 3-year follow-up, still pretty short, 25% good, 8 fair, 6 poor. Some of the poor results related to olecranon osteotomy. Wear does progress over time, and only 5 were at that point revised to a total elbow. So I'll kind of leave that complex topic there, and we can take question and answers or continue to move on. I'll let Jeff and Kimberly lead.
Well, Hill, I just had a few questions. Thanks. And I did ask Hill, in addition to some clinical things, I did ask him to give us some of his reflections on his practice and his thoughts on practice that we could incorporate. I did, Hill, that was great. I had a blast putting this together with you. I learned a lot of things in terms of the Hemi-Hamate replacement arthroplasty. I like that tip that you had about shaping the recipient site in the base of the middle phalanx to sort of hedge it, to bring it around to make that, that concavity. And then in the elbow capsulectomy, pointing out that getting the medial lateral gutter osteophytes is key. I wanted to get your sense on total elbows and what you've seen from your experience, and then being a recipient for problems that others have had. What do you think is the lower limit age-wise on total elbow arthroplasty?
Yeah, that's a great recurring question. So age is not a number, right? Um, yeah, I was lecturing in Tampa once, and a cab driver picked me up, and he had lived in Crested Butte. I live in Telluride, and he says, you know, the difference between Tampa and Telluride is in Tampa, you're a young fart, but in Telluride, you're an old guy. So it's not chronological age, it's activity. So people do better with inflammatory arthropathy than they do with post-traumatic, just because they have limitations. They do better with the non-dominant than the dominant. I think golf is a no-no. So I think certain things are just no-no. So yes, I think if you apply a number, 65, 70, ideally, but oftentimes that just doesn't work. But it is kind of activity related more than anything. And that's where I think you have to be really careful. You know, everyone says you need to keep them on a 5-pound weight limit. You know, a gallon of milk weighs 6+ pounds at refrigerator temperature. So it's less than a gallon of milk. So clearly we're not where we need to be with total elbow arthroplasty compared to hip and knee.
All right, there's a question from the audience, and now we're switching gears a little bit. With your experience with Hemi-Hamate arthroplasty, have you ever noted patients to have morbidity associated with the harvest, either pain or difficulty with range of motion, difficulty bringing their hand around and capacitance and cupping?
Yeah, a great question. And that was one of the concerns we had when we first started doing this. So the very first case that I did, we protected the carpometacarpal joints, and then we discovered they didn't need to do that. I didn't put into this talk, but John Capo in New Jersey put together a lab study looking at stress to the carpometacarpal joints after harvesting the hamate. The key ligaments are palmar, so you don't find issues with stability at all. And we found very few patients with any symptoms related to the harvest site. You know, initially I was concerned about that, and the backup was, well, if we really get into trouble, we can do a 4th and 5th CMC fusion, which still works pretty well based upon motion around the rest of the hamate. So surprisingly, we haven't found issues with that, and lab studies that John Capo did with us, you know, have underscored that also. Good question.
Great. So Hill, why don't you reshare your screen and then start in on your sagely reflections, as I called them. That was my term, not Hill's term. So I'll take the fall for that.
Okay, so this could or should be a whole talk in itself. So I'm sorry for that, but I think the number one thing is enjoy your patients. Rather than treat them medically, it's really rewarding to learn something special about every patient. So even to the point where you might make a note in your chart about something special about that person, you know, non-medical, you know, their wife, their family, sport, something that you can connect with them. And it does a lot for making it fun because you know something more about your patient, but also connecting with your patient. As physicians, we know what to do for our patients, but that doesn't always coincide with what patients understand or anticipate. So listening to your patients is super important. Even though we know a procedure or conservative treatment that we think is the way to go, you really need to solicit what your patient thinks and wants. Thirdly, I see a lot of physicians want to hold patients at arm's length. They don't really want to share their personal life, their personal things. But I think there's great reward and benefit to sharing yourself with your patients. If you look at physicians that may have taken care of you, those that are really personable and you feel like you understand, you tend to like a lot. So I think there's great tendency for physicians to try to hold their patients away. But I think the more you open yourself up to them, the more they come to trust you, and the better it is. Early in career, oftentimes you're going to have complications or difficulties, and early in the career, you may find that you want to hope that that'll get better. But as you go along, you find that the best thing to do is embrace the difficulty or complication, talk to your patient about it, and treat it head on. In the long run, you save yourself a lot of headaches, and your patient will appreciate that. By the end of residency or fellowship, very few of us really have mastered surgical skill. It takes years and years. But the way to get there, you can do video analysis, which is super helpful, but you should never finish a case without taking a moment to think about what went great, what didn't, what you do differently. And certainly don't go to bed at night without kind of running through that. 6, we live in a competitive world where some practices think that other practices are competitors, but we aren't. We're all colleagues with the same amazing privileged profession that we have. And there's great benefit to supporting every colleague, even in other practices. And sometimes down the road, practices coalesce and a practice that someone was conceived as, quote, a competitor no longer is. So we should embrace every colleague and kind of fight the notion that there are practices that are competitors to one's. Technology does change. New procedures, just like what we've been showing this last hour, change. So don't accept them until you have some results and publications of how they do. But on the other hand, we're in a changing world and you need to embrace that change. And so it is incremental. If you accept new ways of doing things, it happens incrementally. And over 5 or 10 years, you may be in a radically different position, but in fact, it's happened with small increments. Let's see if I can advance this. 8th, become an expert. There's great benefit to taking one part of your practice that you're super excited about and trying to become an expert in it. Number 1, it makes you a better surgeon, but number 2, it gives you some sustained satisfaction. You're not going to get bored with your practice and it'll benefit your patients. And then lastly, we all are the beneficiaries of people that trained us, people that taught. And it is our responsibility and it's also our joy to share our trade and teach it on to others. Early in the career, some people can make, lots of us make short-term decisions with immediate gratification that defer work on harder, but perhaps more fulfilling activities, such as becoming an expert or time with marriage, children's, friendships, or volunteerism. I call it the death by 1,000 cuts, where you start working and you kind of lose track of really where you're headed. Kate Blanchett, for example, said a career is built by as much what you say no to as what you say yes to. So you might consider writing down 5 goals you want to spend most of your time on, and then say no to everything else. And don't follow what others expect of you, but follow your passion. Probably multitasking is one of the biggest dangers in our current life. As we know, it increases time to complete a primary task. And a lot of people feel that busyness is kind of a code of honor, and most physicians act that way. But actually, downtime is creative time. And a lot of studies have shown that you can indeed increase your productivity while taking more breaks and playing more. So make time, you carve out time in your life, and you'll find that it gives you time for creative thoughts and does make you more productive, even though you're taking breaks and playing more. So hopefully one of these things will give you something that will be of interest and help your career. Thank you.
Great. Thanks, Hill. So a couple of questions have come up. One is again a sort of a sagely reflection type question, and it's what has AO trauma meant to you in your personal life and your professional life?
Well, AO is it's a family. So it's been one of the most important things in my life. It has connected me to friends all over the world. It has been the leader in education. So if you look at most companies now, they play a big role in education, but AO really was the model for combining new developments with technology. So it's hard to put a finger on that. It's hard to put a value on what participating in a group like AO or AO International or AO North America is, because there are such amazing benefits that you just can't quantitate. You know, it's something you feel, it's something that you share with other colleagues, and in the end, that's all you have is colleagues and friends and family. And when you're working on a collaborative effort, teaching or developing things, AO trauma is an amazing venue for doing that.
Agreed.
So thanks.
Thanks. I thought that was a great question. And then another specific question about Hemi-Hamate arthroplasty. A couple of points, any role for plate and screws versus just the 2 screws? And then any concerns or any experience with FDS, attrition, tendonitis, etc.?
Yeah, great question. Yeah, so I use 3 1/0 screws. So what I do is I take a 0.028 K wire to provisionally fix it near the joint and in the central part of the graft. And then I put in 2 1/0 screws on either side, and then I swap out the K wire for another 1/0 screw. The K wire is the shaft diameter of a 1/0 screw, so it basically is your pre-drill. Where you need a plate is the ones where there's 70 or 80% joint loss. So basically you just have a thin part of dorsal cortex or bone that those screws can hold into. And the thinner the bone, the thicker the bone, the better those screws hold. And the thinner the bone dorsally, the more dangerously they hold. And so the ones that are 2 scenarios. One, an unpredictable athlete, a hockey player that walks in with his pants halfway down that may not respect your protocol. So a plate, a small mesh plate will help with that. So I use a 1/3 mesh plate, cut it down to 4 holes, and usually just a couple of those to fix it. And the second scenario is just what I said. When you have just a small amount of bone dorsally, then I think the screws alone are not quite enough. So that's a great question. I don't know about FDS attrition. What I do is I repair back the volar plate, and you can do that because the margins of the volar plate, medially and laterally, are pretty robust. And there's always tissue right where the collaterals attach on either side. So there's always tissue to repair back. And then the flap, the retinacular flap between the A1, A2, and A4 pulleys, I reflect underneath the tendons on top of the graft. So there's one more barrier, that retinacular flap between the graft and the tendons. So I can't say I've individually tested, everybody's FDS, but I haven't seen obvious failures from that. Good question.
Great. Yeah, excellent questions. So we are approaching an historic moment in that we're actually going to end on time, which is fantastic. Chai, any thoughts?
No, I think that was really superb, Dr. H. Thank you so much on behalf of the entire AO North America Hand Education Committee. That was spectacular. Thank you. And Jeff, that was wonderful. So I'll leave it to you to do the closing stuff and hand off. Thank you very much.
Okay, everyone's going to see an evaluation. We'd appreciate your feedback on that. And then one last thing, we do have our ongoing webinar this Thursday. And again, some reflections on residency and fellowship wrap up and some things to know and some decision-making help in the future. Thanks, everyone. Thank you so much, Dr. Hastings. That was great, Hill.
Thanks, everybody, for taking your evening to log in. It's an important thing you've done, I think. I appreciate it.
Thank you.
All right. Good night, everybody.
All right. Thank you, Jeff.